Hello everyone, this is Riley with Becca. Thank you for joining us for today's webinar, Preparing for What's Next in Language Access, Navigating Regulatory Shifts and Sustaining Equitable Care. Before we begin, I'll walk us through a few quick housekeeping instructions. We will begin today's webinar with a presentation. You can submit any questions you have throughout the webinar by typing them into the Q&A box you see on your screen. Our webinar today does include closed captioning. Please feel free to toggle the font size and preferences in the box on the bottom of your screen. The widgets on your audience console are also customizable. Feel free to drag, expand, and rearrange the boxes however you like to best engage with our session. Today's webinar is being recorded and will be available after the event. You can use the same link you used to log in to today's webinar to access the recording. If at any time you have issues with audio or visual, try refreshing your browser. You can also submit any technical questions to the Q&A box. We are here to help. With that, I'll turn the floor over to Matt to get us started.
Well, hello, everyone. Thank you so much for attending our session today. Welcome to Preparing for What's Next in Language Access, Navigating Regulatory Shifts and Sustaining Equitable Care. My name is Matt Fidler. I'm the Vice President of Client Experience for AMN Healthcare Language Services. And let me begin today by thanking you and your teams for the outstanding work you do to connect patients in need with outstanding care. Thank you. It certainly is a dynamic time in healthcare these days, which generates countless questions for our teams. What do recent announcements by the current administration mean for my health system? How are others of our peers continuing to progress health access and equitable care for patients? I'm so excited to be joined by our panel of experts today to address these questions. First, I'll welcome back Drew Stevens of Parker, Hudson, Rayner, and Dobbs. Drew is a frequent guest on our webinars, and I'm thankful for his insight today. Joining Drew will be Rosangela Cruz Rojas, who is the Chief Diversity and Equity Officer at Mainline Health in Philadelphia. Katie DeWitt, the Compliance Administrator for Catholic Health based in Buffalo, and Carlos Martinez Morales, the Language Services and Cultural Competence Manager at Intermountain Health. I'd also like to thank our two ASL interpreters today, Audrey and Lisa, for their help today during our session. Would like to remind folks that this presentation is for general information purposes only. Nothing contained in the presentation or said during the presentation constitutes legal advice. So during our session today, we've got three distinct parts. Next, I'll hand it over to Drew to cover the topics based on the recent administration's information. From that point, our three additional guests will join us to speak through their expertise, their point of view, and some of their best practices that they're applying in their systems. And then finally, our panelists have prepared some questions for Drew that we will then pepper him with from that point moving forward. Thank you all again for being here. And Drew, if you could take us away, please, on your briefing topics.
Sure. Thank you, Matt. And thanks to everyone at AMN for having me back. And thanks to Becker's for this opportunity as well. And thanks to all of you for joining. I see we're up to about 156 attendees at the moment. So really appreciate your interest in this topic. So this first slide here, I've set out what I'd like to cover with you over the next 20-25 minutes. I'm going to start by summarizing two recent executive orders that President Trump signed, the first being the English as official language executive order, and then a second executive order related to disparate impact claims of discrimination, and summarize for everyone what these orders do and do not do as it relates to language access. Then we'll spend some time discussing state laws and other regulatory compliance concerns that remain relevant today. And then I'll spend a good chunk of time summarizing the enduring importance of Title VI of the Civil Rights Act of 1964, which fundamentally serves as the basis for language access rights in the healthcare space and across different industries as well. And then we'll conclude with a short discussion about what remains to be seen with the next expected iteration of the regulation under Section 1557 of the Affordable Care Act. So the English as official language executive order, there was a lot of confusion coming out of what this executive order did and what it did not do. Principally speaking, this executive order essentially just rescinded an executive order from 2000 that President Clinton had signed. That executive order had been entitled Improving Access to Services for Persons with Limited English Proficiency. And here on this slide, I've got an excerpt from the English as official language executive order. And the key text here, apart from revoking the earlier order, is the directive to other agencies, the agency heads, to make decisions that they deem necessary to fulfill their mission and efficiently provide government services to the American people. So it concludes by saying that the agency heads are not directed or required to stop producing documents in a language other than English or providing services in languages other than English. It just simply kind of punts the issue to agency heads to determine what is appropriate for their agency to do in terms of providing language access to government services. So to my knowledge, nothing significant has changed, or at least been publicly announced in regards to this order, though others may have anecdotal experiences regarding any shifts in response to this order that I would certainly be interested to hear more about. So what did the order not do? It did not rescind the 2003 LEP guidance from HHS, for example, and it didn't change any laws or any court orders or interpretations, of course. And what's interesting is this morning I got on HHS's website just to confirm that all of these various fact sheets related to the 2003 LEP guidance and just language access in general are still up on HHS's website, though the actual guidance itself from 2003, that link is gone, but it is still available in the Federal Register. The official publication of the guidance is still online because it hasn't been rescinded. So it'll still be there. So this suggests to me that this administration does not intend to upset the apple cart and undo longstanding expectations, legal or otherwise, around language access in healthcare, because all of this remains online. But that's just trying to read the tea leaves there. So the second order takes a little bit more of an explanation, in that I first need to make sure we all understand what disparate impact discrimination is. So in general, discrimination claims can be based on intentional conduct or unintentional conduct, and the unintentional conduct is referred to as disparate impact. That is a reference to when a facially neutral policy or practice disproportionately burdens or affects a protected class unintentionally, but it's just the effect of it. That's disparate impact discrimination. And there's much more disparate impact discrimination litigation in employment, for example. That's a very high profile example of where these theories are often litigated. And so this executive order directed the federal government to deprioritize enforcement actions on the basis of these unintentional theories. And it also directed the federal government to repeal or amend any regulations that contemplate disparate impact liability. And Title VI does have a regulation that contemplates disparate impact discrimination. But as I'll explain in a few minutes, this really doesn't change the landscape for language access in healthcare. And so what did this disparate impact executive order not do? It didn't change any protected classes under Title VI, including national origin, because executive order cannot do that. Title VI was passed by Congress in 1964. Only Congress can change the law. So how does this all relate to language access in healthcare? Traditionally speaking, language access rights were thought to be based on disparate impact discrimination. The failure to provide language assistance services has the effect of discriminating against individuals on the basis of national origin, is the protected class under Title VI. But in a few minutes, I'll explain how that may have been the traditional understanding, but there's a whole variety of theories that could be premised on intentional discrimination. So even though the disparate impact discrimination theory is being deprioritized, the federal government was not active in this area anyway as it relates to language access in healthcare. So it's essentially putting everyone back where everybody already was. It didn't really, it's not going to really affect any government enforcement in this particular area because there hasn't been federal enforcement to date in this area. So this next slide I have here, I just wanted to call everyone's attention to the now even greater importance of state and local laws that bear on language access rights in healthcare. And the National Health Law Program has a great comprehensive summary. I believe it was last updated in 2019, so everyone should consult this resource and then look for any new laws or make sure the laws referenced there are still in effect. But this is a place where everyone should go to get a greater sense of what their particular state or local jurisdiction may require of them as it relates to language access in healthcare, because nothing that the federal government is doing is going to affect those state laws, for example. Then we should all also keep in mind that the Joint Commission has various standards and regulations, accreditation standards that bear on language access in healthcare. So the new requirements related to an accredited hospital's requirement to actively take steps to reduce health disparities. Included in those requirements is the expectation that hospitals are communicating with their populations in languages that they understand and providing meaningful access to those patient populations. There is also the excellent outcomes for all certification, what was previously known as the health equity certification, that hospitals can aspire to, and many of them have achieved that certification already, and that would also have independent requirements related to language access. And where this kind of comes full circle is an example, the Massachusetts Medicaid waiver, which essentially adopted the Joint Commission standards that we just discussed and made it a part of their Medicaid program. So there you have the direct tie of Medicaid reimbursement to additional language access expectations beyond what is even in Section 1557 or the regulation or Title VI. So these continue to apply, and everyone should continue to consult them regardless of anything else that we've been discussing. So this brings us now to what I consider to be the North Star of language access in healthcare, and that's Title VI of the Civil Rights Act. Many of you who may have attended any of my talks in the past would know that Title VI was something of a monumental transformative law in our nation's history that effectively desegregated healthcare with the dual advent of Title VI in Medicare and Medicaid in the 60s. Healthcare had previously, sadly, been segregated by race, and this influx of federal funds, together with Title VI, effectively desegregated the entire industry in a matter of weeks and months. It was that monumental. But in 1974, the U.S. Supreme Court had issued a foundational ruling in this context, the Lau decision, in which the U.S. Supreme Court affirmed in an educational context that the failure to provide educational instruction or materials in a language other than English can constitute national origin discrimination under Title VI. So this is the entire real legal basis for language access rights as emanating from Title VI and its prohibition on national origin discrimination. So something happened in 2001, however, where the U.S. Supreme Court issued the Sandoval decision that civil rights advocates and commentators have long lamented this particular decision. This decision held that while national origin discrimination can extend to language access or discrimination based on a failure to provide meaningful access. Only the federal government could bring a claim for unintentional or disparate impact discrimination on that basis. That left, after this 2001 decision, that private individuals could only bring national origin discrimination claims under Title VI if they allege intentional discrimination. So they'll need to allege intentional discrimination, produce evidence that the discrimination was intentional. So this had the effect of essentially taking enforcement at the enforcement at the private level of these types of claims, disparate impact claims, down to zero, because private parties could not bring these claims. And because the federal government was not bringing these claims either, there's virtually no disparate impact discrimination enforcement under Title VI in the healthcare context since 2001. But intentional discrimination can mean and can be shown in a lot of different ways. So that takes me to I'm just getting a resource here up for me. That takes me to the Lucas decision from the Fourth Circuit Court of Appeals in 2025. So earlier this year, one of the Federal Court of Appeals affirmed that Title VI extends to intentional discrimination. A private individual can allege intentional discrimination under Title VI. In that case in particular, a patient had lodged a complaint with a hospital, so it's a healthcare context, that she felt that she had been discriminated against on the basis of her race. And then she alleged that the hospital terminated her as a patient in response, essentially a retaliation type discrimination claim. Well, her claim had been dismissed by the lower court, the district court, but the Fourth Circuit Court of Appeals reversed and revived her claim on the basis that she had adequately alleged deliberate indifference on the part of the hospital or health system to her rights. So what she had alleged was essentially a hospital manager was aware of her complaint and aware that she had been terminated as a patient, and that decision maker with the hospital failed to take any action to correct it. So the health system, the hospital itself as an institution, could be held liable for that alleged discrimination on the basis that it was deliberately indifferent to her rights. And this is one way that intentional discrimination can be shown. And typically, it's typically what you see in this context, in the healthcare context. Sure, there may be cases where there's true animus towards an individual or his or her race or protected status, national origin, for example. But typically, when everyone is acting in good faith, you would see a deliberate indifference type claim where someone is aware that there's a failure and fails to take action. So in the language access context, you could easily imagine that someone is requesting some sort of service so that they can have meaningful access to their health care. And when that is not provided, so long as the decision maker was aware, then this type of deliberate indifference claim can easily be asserted under Title VI. And then there's, even apart from deliberate indifference, there's a host of other ways of alleging and showing intentional discrimination. The DOJ, the Civil Rights Division of the Department of Justice, a few years ago, and I have this on my desk, I'm happy to send it to anybody who would like to see it, put out a document summarizing the ways in which you could show intentional discrimination under Title VI, and summarized recent documents, pleadings that they filed in court, many of which were language access cases, where the Department of Justice, under the Biden administration and previous administrations, were supporting claims in court that they were not a part of, and making clear that the law supported an allegation of intentional discrimination. That could be showing an entity's knowledge that individuals with limited English proficiency come in their door, knowledge that they aren't provided services, and this has a negative effect on them. So the history and knowledge of an institution would be relevant. Statistics, what services are provided to others. And there's also this theory of proxy discrimination. So there's been cases that have found that language access can be used as a proxy for national origin discrimination. So the failure to provide language access is, under this theory, a proxy for national origin discrimination. So that theory also still applies here. Before I move to Section 1557, I want to note just one item, the last item on this slide, which to my mind confirms the enduring significance of Title VI. The Trump administration just recently announced what it's called the Civil Rights Fraud Initiative. This is brand new, and this is based on the idea of using the False Claims Act, which is designed to essentially punish and deter and recover funds for fraud on the government. And it is such a significant law because there are per claim penalties, and the government can recover treble damages. That means triple damages. Then private individuals can stand in the shoes of the government. This is what's called a qui tam relator for any of you who have had exposure to these investigations or claims. Private individuals can bring these type of False Claims Act cases. Now, if you look into what the Trump administration intends to do with the Civil Rights Fraud Initiative, it's advancing the new administration's policy preferences. And so language access is not listed in the examples of what it would consider fraud on the government, civil rights fraud, with the failure to provide language access. But I recently published an article on this, so you can confirm that I did in fact say this, but individuals can use these types of theories to conceivably allege that the failure to provide meaningful access is a violation of Title VI, and that gives rise to this type of civil rights fraud theory under the False Claims Act. So it's just an example of the enduring significance of Title VI, and it's something to pay attention to, this new civil rights fraud initiative under the False Claims Act. So the short version of all of that is that everything that we just discussed has kind of taken us to where we started. Language access in healthcare, the law is basically still the same, notwithstanding the executive orders that we've discussed. And of course, the regulation under Section 1557 is still in effect to date. It is still the Biden administration's regulation. And so from a legal perspective, every hospital or health system should still continue to be complying with that regulation that is in effect. Otherwise, you're exposing yourself to a potential investigation or claim from the government, notwithstanding that it was enacted under the earlier administration. So that's meaningful access, that's language access procedures, that's the requirements around AI-assisted translation, qualified interpreters, all of that is still in effect. But what remains to be seen is what will the second Trump administration do this time around with this regulation, because it is evident that the administration will issue its own version like it did the first time, but there's a number of issues that need to be worked through because this regulation is so expansive. Now, considerations around AI will be deliberated. There's obviously a host of issues around sex discrimination or religious conscience discrimination. But the two big questions on my mind are, will the administration provide the public with the opportunity to weigh in on a proposed revised regulation? Many of you may have seen an announcement from HHS several months ago now that indicated an intent to not provide notice and comment for certain regulations. It did not specify which ones, that HHS thought it did not need to do that. Now, the norm would be HHS would provide notice and comment on a proposed regulation. That comment period would be open for months, and HHS would need to respond to those comments before finalizing a regulation, because that insulates the regulation from challenge under the Administrative Procedures Act. But it is possible that the new administration will determine that it does not need to do that, and it may just rescind and finalize a new regulation. We'll have to see. But I'm expecting it will take time before the administration is even prepared to do that, because of the number of issues that it will need to decide what its policy will be on things like AI and human interpreters, for example. And then the big question will be, from a language access perspective, will the next version of the regulation look like the one from the first Trump administration, which kept in place, by and large, the regulatory requirements around language access, which is easy to overlook how important that was, because the Obama administration's regulation, the first one, was pretty monumental in turning meaningful access into a regulatory requirement, and then having specific prohibitions on things like using minors as interpreters, children as interpreters. That stayed in the Trump administration regulation, this general framework, and that's pretty momentous. And so we'll have to wait and see whether this next iteration keeps the same structure. Is it going to be similar to the first version of the regulation? But I do anticipate that this next version will nix some of the more expansive regulatory provisions under the Biden administration, such as requiring language access procedures as opposed to language access plan or something like that. So it would be, I'll conclude with this before I turn it back over to you, Matt. In my personal view, it would be a radical departure for the Trump administration to take some sort of interpretation of Title VI or anything like that to undermine this general framework that federal law requires meaningful access to LEP individuals in healthcare. I would think that would be a radical departure, especially considering that was not what happened in the first Trump administration. So everyone will need to wait and see and review that regulation. That's where I think we'll really know what this administration's position is on these specific legal issues that we're talking about. So with that, Matt, I'll turn it back over to you.
Thank you, Drew. Appreciate it. Such a dynamic time, and I appreciate your insight and your guidance on these pieces. And I think there certainly is more to come, as you suggested. This is the landscape as we know it today, and I'm very thankful for your insight into that, Drew. So one of the things that we certainly want to accomplish with the next piece here is to bring in some experts in our field, some folks, some practitioners, right, out in systems today, working through this and advancing the cause for language access. One of the questions we get most is, okay, great. So what's everyone doing, right? Given what Drew has shared with us, what is our peer set doing, right? How are we continuing to drive this based on what Drew's provided, but also based on the individual intent of everyone's health systems and what they're working towards. So again, I'm so excited to introduce the panel that will be sharing their wisdom, sharing their insight, sharing their stories about how they drive progress within their systems. Carlos Martinez Morales from Intermountain Health, Rosanceli Cruz Rojas from Mainline Health. So I will start with my first question to Katie, please, and then to Carlos, and then to Rosanceli. So given everything that you've heard Drew discuss so far, and given the conversations you're seeing in your own systems about these executive orders, about the federal regs, has anything changed with you and your organizations and how you approach language access? Katie, can you weigh in on that one for us, please?
Sure, absolutely. First, I'd like to say thank you for having me here today to share with you what we've been doing in our system. We've actually been offering more services across the board to our patients because we know in the way things are going today, especially in some of the bigger cities, and we're a refugee city, we want to make sure that patients are feeling welcome in our facilities. So we've actually increased as much access as we possibly could across our system, including adding extra devices in most of our facilities that take care of patients with more language needs. For example, we have a lot of patients in the city of Buffalo who speak different languages, and on our labor and delivery floor one day, we had 13 patients that spoke different languages all in labor at the same time. Originally, 2 devices would be on that floor, and now we have enough that we can make sure everyone has what they need when they're there to make sure that they're getting the best care that we can give them.
Awesome. Thank you very much. So Carlos, same question to you, please. What is your opinion, your view of this at Intermountain, please?
Yeah, I think we're staying the course. If anything, in some areas, like she mentioned, we've doubled down when it comes to ensuring that our services are obvious to the consumer or the patients, and that they're more readily available for our employees, our workforce. Adding devices, enhancing our ability to use these services through our telehealth systems and the equipment that is built into the rooms in the patient floors, to engage interpreters that way, to not be so dependent on the rolling tablets, and doing a lot of education. If anything, I think for a while there, whenever we were talking about language access, Section 1557 kind of was the regulation that I was tending to go to, because it was the most current, the most, the newer one. If anything, I'm going back a little bit to Title VI as a point of reference, just to ensure that if anything were to change with the Affordable Care Act, it is understood that nothing changes with Title VI, like Drew was explaining. So when it came to our policies and updates, maybe that was a little emphasis that was different. But when it comes to our access, and we're staying the course and ensuring accessibility more than ever.
Yeah, Carlos, thank you. I appreciate that. And certainly, referencing the bedrock that is Title VI, makes good sense, even though we heard Drew say, the ongoing requirements for 1557 still remain relevant. But Title VI is so, as I said, is bedrock in this space. Rosangela, you've joined us as well. Thank you for dialing in via phone today. We appreciate it. I wonder if you might share your opinion on this question as you progress the function at Mainline Health, please.
Thank you for the opportunity of sharing our experience as well. So at Mainline Health, what we've been working on is continuing to. Sorry.
Rosangela, are you there? Can you hear us? All right, so perhaps we're having some technical topics. Rosangela, any chance you're there? Okay, so I'm going to pivot to the next question, and then if we can get Rosangela back, we will loop back around. All right, cool. So Katie and Carlos, so now that we've talked about again, sort of the consistency with sort of the core from a compliance standpoint, and why these are offered. What I'd love to hear now, and the questions that we're asked a lot are, okay, but we do this for reasons beyond compliance. We do this for various reasons on how we help connect patients that are in need. And I wonder if you might talk a bit about the motivations or the intentionality beyond compliance that your health systems cite or choose to use as they continue to invest and grow their language access programs. And Katie, if we might start again with you first, please.
Sure. So along those lines, our hospital system, the first hospital we had was actually founded in the 1800s to serve immigrant populations that no one else would help. And since we've grown as a system, our motto has become the right way to care, meaning that we need to offer the right way to care to every patient, no matter what the rules and regulations are, whoever's in office, whatever is changing. So along with that, we've done a lot of internal introspection. I've actually done a lot of going through the floors of our hospitals, asking our clinicians, how can we make this easier for you to utilize and offer it to most of our patients? We look back at who we're serving, right? What do they need? How do we make them feel welcome in our facilities? How do we reduce their readmission rates? How do we make sure that they're being taken care of and getting their medications and follow-up appointments? And with that, making it as easy as possible for our clinicians to utilize the services. So one of the things that we've done is to help, we're working on is integrating into our Epic system so that we can take away some of the documentation piece from our clinicians so they're more likely to offer the services because it's one less step that they have to take. Re-education is huge, making sure that everyone knows the services are available and really making sure that they know that we're doing this so the patient feels comfortable. We've even done examples of walking into a room and then saying, you know, if you are a patient and we have, you know, our nurse are English speaking, and we had somebody walk in and they pretend to be a patient, the nurse, and we have somebody come in that speaks Spanish or Arabic or Farsi to them. And we said, now, did you understand what they said to you? Would you be able to take that information home with you and take care of yourself? And they're like, no, there's no way we could. We said, well, that's kind of the problem, right? The patient is hearing you, they're hearing what you're saying, but they don't necessarily know what you're saying. They don't know how to reply to that. They don't know what that means when they go home. Their family members may not understand. And to get that across in an actual interaction makes them more likely to.
That's great. Thank you, Katie. So I love the concept of that immersion. And sorry, you broke up a little bit there at the end. It may just be my connection. But Katie, I love that because it's that sort of that day in the life, right? It's putting ourselves in the shoes of the patient and really understanding and sort of assessing our own selves in terms of, you know, what truly is retainable for that patient and walking a mile in their shoes. I love that piece. Carlos, I wonder if you might carry on that same question, please.
Yeah, I agree that beyond compliance to regulations, it's just the right thing to do. And hopefully you work in a system that has that as one of their values, right? That equity or inclusion or, you know, community welfare, whatever they call it, that they have a value and a mission to serve the communities and understand that you need to serve the entire community to have health, right? Like at Intermountain, our logo is helping people live the healthiest lives possible, but everyone in the community needs to be healthy for that goal to be achieved. And the new ways that we're being reimbursed, looking into the financial side of things, our readmission rates are that revolving door in the emergency room that happens when patients don't understand their care and have to come back. All these things are being measured against what the hospitals and healthcare institutions can receive as reimbursement from Medicaid, Medicare services from the federal government. So there is a financial component to this that oftentimes, even though shouldn't be our driving force, right, to do the right thing, is a language that some of our leaders understand. And when you're able to put it in that context, I think that helps get a lot of buy-in from those who can make decisions. Aligning ourselves with those goals and those system goals, and helping people understand how language access fits into that and the impact that the populations that we serve have on the overall performance of a hospital, I think is a key component to get that buy-in from people to ensure that we are ensuring language access and seeing the benefit on patient safety, on our both patient but also employee satisfaction scores, that they feel that they are supported and that they can really serve the communities. I think that's a good message, an important message to do. We were able to, a couple of years ago, align language access to one of our equity goals. And as a system, everybody had a goal. And they came to me and asked, you know, what a lot of people think language access is an area that inequity that we can do better at. So how do we create a system goal that involves this? And And we created a goal around documentation. Documentation has been very spotty. And I thought, if we can create a goal, something we can measure, how often when a patient that is LAP or deaf or hard of hearing and needs interpretation has a documented event of interpretation services, we're going to drive compliance, right? We're providing interpretation because people are going to want to meet this goal. And that was a big key turning point, right? Where we were able to go from documenting about 30% of the times to ending the goal 2 years later, documenting 89% of the time. And that was, obviously that doubled, sometimes tripled our interpretation events. But it really helped everyone get on board with this idea that this is important, right? That this expectation is not just something nice to do. It's not only the right thing to do or only the legal thing to do, but it's something that the organization had a commitment for because it was one of our 7 main KPIs or key performance indicators for the organization. And that was, I think, a huge win. But that came from building these relationships with our compliance officers, our legal departments, and those key allies that we have, those champions that we can find who get it, right? And I think that's key. If you're in a situation in your organization where you're trying to get that message across, is find those champions, find those people that really get it, and get them on your side and help amplify your voices even in those rooms where you're not invited in, so that your voice can be heard throughout.
Carlos, I appreciate that. You touched on 3 things that are just awesome, and we're gonna put a pin in one and come back. So the first definitely was the tie-in to the financial piece, and that will be the topic for our third question for sure. There's 2 other things I really loved there. Number one was sort of piggybacking on a system goal. So as you mentioned, Intermountain Health had a number of key KPIs that everyone in the system shared. And forgive me for paraphrasing for you. So many times, when we talk with folks, they feel like they are trying to start everything from scratch. But you did a really good job of understanding the importance and the weight of those KPIs around Intermountain Health, and really leveraging them to help drive your progress. And so I think that's an awesome call out. I've been lucky enough to hear Carlos tell that story about the compliance improvement from about 30% to I believe you said almost 90%. And unfortunately, our audience is all muted, but usually that's a big wow that we hear from folks because of the awesome progress that brings about. I think we have Rosangeli back, and I would love to get your thoughts on this question, Rosangeli. You've spoken with us in the past at Mainline about how health equity and patient safety are really driving the driving factors, the driving motivators for you above and beyond compliance. Might you speak to that for us, please?
Thank you. And I'm sorry, I've been having some technical difficulties today, so my apologies for that. And before I go there, I just wanted to respond to the question, have anything changed? No, it has not changed for us. In fact, in between January and March, we have increased the number of devices that we have made available for our patients and for our community, simply because it is very important for us to ensure that every patient has the same level of access. And one thing for us is that at Mainline Health, we always do our care by following STEP, which is safe, timely, effective, efficient, equitable, and patient-centered. And if we are following that, providing care in the language that the patient needs, it is important, because we're going to be avoiding issues of safety, because we're going to be able to provide the care timely at the moment, at the time where the patient needs that to be more efficient and effective. And therefore, it's going to be equitable and patient-centered. So I think that's part of the reasons we go there. And we have been in our mission, vision, values, clearly articulated that safety, highest quality, and equitable care is what we want to provide. And that's what centers our decisions about whether we invest more in language services or not. And then another piece for us is that in the past few months, there was a closure of a hospital in in the neighborhood. It's not part of our system. And in that hospital, a great deal of their service area, which now we are absorbing, we have a large number of patients who, speak other languages other than English. So very important, particularly in this moment, to just continue to double down in the amount of services we provide.
That's great. Thank you. It's nice to hear your voice. I'm glad we were able to get you back on the call. If I can spotlight one component of that, it really was the mnemonic, the STEEP, S-T-E-E-P mnemonic. And I love that because it is easily graspable. It is very understandable. It is sort of baked into the culture within the system. And I love it when we're able to utilize those mnemonics or those devices so that it remains, the goals of these teams remain sort of top of mind for all folks involved. Thank you all. Thank you three very much for sharing that information about reasons why beyond compliance this continues to be an area of focus. And Carlos, you raised a topic that I think a lot of folks on this call have a strong vested interest in, which is understanding how these efforts drive the financial value or drive financial success for health systems. And so, as you all have eloquently spoken to, systems provide language access because it's the right thing to do, because of the desire to, have and provide equitable care. But sometimes what helps make the story even stronger is having a very robust story about how this impacts the financial state, the financial status of the system. So I wonder if you three might, again, in round, speak to how you are tying your team's activity to system financials. Katie, can you start with us, please, from Catholic?
Sure. So my background actually before I got into language services was in research. So when I tried to show anybody anything, my first thought is, let's make a study out of it. So what we started to do and what we're planning on doing with our Epic integration is a research study based on LEP patients and whether or not we are having lower readmission rates, better outcomes based on services being offered more often. And with that documentation that we're going to have in there, it'll help us to actually see what is going on. And as we all know in our systems, if money wasn't an object, we would absolutely be able to do all of the things that we want to do, but we know that that's not the case. So my goal is to show that we're going to have patients coming back less, patients being less sick when they do come back, increasing our off-site services, making sure that people are coming into their cardiologists or say nutritionists or whoever they need to see based on their diagnosis, because they were able to understand discharge instructions better and show it that way. Because we all know that, we get dinged for readmissions, we get issues with more payments or less payments based on all of those things. So by being able to show that to the leaders and the stakeholders, they're saying, oh, wait a minute, just offering language services to these patients actually will cut back on our costs. Even though we're paying a little more for the language services, we actually will save a lot more in the long run. And that's my goal, is to show them that over time. The other things that we've done to make things a little bit easier is we have Rover devices on all of our floors, and we also have iPads for our nutritionists to help order food for patients when they're in our hospitals. We've actually put AMN services on all of those devices as well, so that we can do quick options for offering services to patients, so they know wherever they are in our hospital, they are understanding, why is someone taking me to X-ray, or, what am I actually ordering for breakfast? Is it along with my traditions and beliefs and all of those things that go along with it? Again, making them feel more welcome and making people want to participate in this. And the happier the patients are, the more patients that are satisfied, the happier the stakeholders are. So we're trying to also improve those scores as well to show, yes, not only are we saving ourselves money, but we're making our patients leave happier and healthier. And that's our ultimate goal.
I love it when we get a quant, right, a research mind involved in the metric piece of this, because it certainly does help bring some structure to it. So Katie, I applaud you for that effort. Carlos, can you tell us your story, please, on how you continue to maintain really, really strong champion support around your system, please?
Yeah, no, I think anytime you can tie the impact of services on readmission rates and all these other buzzwords, right, that are so key for hospital stats and their accreditations and their reimbursement is key. Having your health records be able to help you track that, making sure that you can document interpretation services, automating the documentation with the integrations with your partners, whether it's AMN or other partners, to ensure that that documentation is accurate and it can flow into the health record. That's something that I think is another big key in having the reliable data that you need to be able to do what Catherine has explained. So I think that's very, very important. Also, you know, for those organizations that have staff interpreters and being able to utilize your interpreters, like the saying says for nurses, right, at the top of their license, being able to have them do video, telephone, in-person interpretation, and tracking their productivity. I think that has been a big factor for us, that we have software that allows us to, we have a centralized dispatch center, right? And from there, all 34 hospitals are being serviced, right? And we know where our interpreters are, what they're doing, when they're available, when they're not, and being able to track their day and their availability and ensure that when they have time in between appointments, they're jumping in to do video or to do telephone interpretation services and keeping them productive has been very helpful to be able to compare the cost of staff compared to just outsourcing everything, and be able to move some of those funds that we were spending on vendor services in-house and have a team. We're up to 138 people in our language services team, but we keep them engaged, we keep them productive, and we're able to grow our department because we have really good data. So I think that's a key component, is have the tools necessary to not micromanage, but understand where your resources are being used and how are they being used and are there opportunities. And then you can look at that data and go like, you know, if I shift a little bit of this more to video instead of in person, or a little bit more to in person for these really long appointments instead of video, my cost per minute overall, which is what we report on, comes down. So being able to know which percentage of the pie you want in each modality and how you're using those resources has been very helpful in gaining the trust of our financial folks to say, oh, you know what's happening. You have data to show not only what's happening, but why it's happening. And that has been very helpful in getting that buy-in to get resources to create the department that we have today, right? With a centralized dispatch center and 9 languages and et cetera.
Yeah, Carlos, I appreciate that for sure. And it is the maturity where your sort of system metrics are and your operational data are is really awesome. And it does provide that visibility, right? That allows you to cite that and to benchmark against that, which is amazing. Rosangeli, I know that you have recently been through a process to identify those key metrics at Mainline. Can you share that story with our audience, please?
Yes, definitely. So one thing that we've been doing for about 5 years now is that we have taken what we call our important quality, safety, access measures in the organization, which we do both for the system as a whole, but also for particular clinical areas. We establish what those key, quality measures are. And we have made a decision to stratify them so that we can see where we have opportunities, whether that is by zip code, by, race, by behavioral status, number of factors, payer, et cetera. And one of the key pieces is language. And what we have found is that, and I'm talking about potentially by now about 100 or more measures that we have done that, say patient safety, measures, adverse events, readmissions, visits to the emergency room, C-section rates, patient experience, and others. What we have found is that there's very clear patterns where we see that there's opportunities by language. When you think about safety issues, we see a higher proportion of them among people who, does not speak English as their first language. We see some other admission rates are higher. Some of the patient experience are not the best. So there's some opportunities we see. Our hope now is that we have increased so much in the past, months, the language services, is that then we're going to look at how much we could be impacting some of these key quality, safety, access measures. We know that there's potential delays that it could be prevented, in terms of receiving care, and maybe in their interactions with physicians and nurses and, the clinical team, that we could probably look and explore in more detail to see if we can, identify how we continue to improve it. So I think for us, that is a key piece, is that we use data in order to inform some of our decisions, and some of the data is in very important metrics that are critical to demonstrate that we continue to work to higher quality and safety as an organization.
That's excellent. Thank you so much. So what I'd like to do now is do a really brief recap, and then I'm going to pose a question back to Drew that our panelists of experts had requested that I ask. But first, I'd like a virtual round of applause, please, for Rosangeli, Carlos, and Katie for being here today and for sharing their wisdom and insight with us. If I could recap 3 things that I took away from that session. Number 1, I think, was the importance of day in the life, of having our providers and having our staff walk a mile in the patient's shoes to truly understand what a patient can take away from the experience. Number 2 is tying into existing system goals and system KPIs. We don't need to recreate the wheel. We need to tap into lexicon or information that is already present and prevalent within the systems. And then number 3, the focus on building out data to help understand operationally and sort of strategically how we continue to make the case and build out the function. So kudos again to our 3 panelists for joining us today. Drew, a quick one for you before we sign off here. One of the things that these guys were really focused on as part of our preparation was this talk about Medicare or Medicaid cuts and what can we expect? Will there be any impact to that? So if you could just pull out the crystal ball, Drew, and sort of tackle that one for us in about a minute or so, I would appreciate it.
Sure. Yeah, this is an important question. And of course, the precise details of the bill are still being determined right now. And what is going to be cut is not at all clear, aside from the fact that there are going to be significant cuts to Medicaid. And as it relates to language access in healthcare, something like 18 states reimburse providers for their language services through Medicaid. So I would expect that significant cuts to the Medicaid program will have a downstream effect in that regard of limiting the amount of funds available for these states to reimburse for these services, which will then likely have a second downstream effect that there will be less of it provided, perhaps, or it will make it harder for these champions to champion language access when there's less funds available.
Thank you for the brief recap. Appreciate it. Certainly a dynamic time for sure as we address some of the statements made by the administration as we think through those Medicare and Medicaid cuts. But I am so excited again for our panelists and the insight they shared about why ongoing efforts in this space are valuable for them and for their systems. Okay, so a few quick comments in closing here. Again, my thanks to Drew, Rosangeli, Carlos, and Katie for attending today. My thanks to Audrey and Lisa for live time working with us today for ASL. Thank you guys very much. A couple comments. The slide deck and the recording will be sent to all attendees early next week. So everything we've covered today, including the recent paper that Drew mentioned during his section, will be included and sent out to everyone. As a reminder, here in the middle section, please do visit AMN's site for the 1557 Compliance Toolkit. It's a really great resource to utilize for you and your systems. And then finally, if you've got follow-up questions from the session today, you can indicate that in the Becker's post-session survey that comes. You can reach out to your client account manager or email the client services email address at AMN Healthcare there. Again, I will end where I started, which is thank you all for everything that you do to connect patients to amazing care. Thank you again to our panelists for their insight today, and I hope you guys have a wonderful day. Thank you all for attending.
That is all the time we have for today. I want to thank Roseanne, Julie, Catherine, Carlos, Drew, and Matt for an excellent presentation, and thank AMN Healthcare for sponsoring today's webinar. Thank you for joining us today, and we hope you have a wonderful rest of your day.